Today, I will be presenting a case conceptualization involving a 60-year-old female client who presents with cumulative grief. Um, I also believe she has ambiguous loss and attachment trauma. This case particularly relevant to our course because it illustrates how unresolved grief can become intertwined with developmental attachment wounds, family systemic dynamics, and nervous system adaptations. My case conceptualization integrates internal family systems, attachment theory, interpersonal neurobiology, and I will discuss the client's presenting concerns, developmental history, theoretical conceptualization, treatment progress, and questions I would like to bring to consultation. I selected this case because it demonstrates the complex interaction between grief and attachment trauma. Although treatment has been progressing well, I continue to wrestle with important questions. One question is whether the client's distress is primarily related to unresolved grief or whether the grief remains activated because of repeatedly touches of an earlier attachment wound, or maybe it's both. Another question involves the role of survivor guilt, ambiguous loss, and parentification. The client is highly motivated, insightful, but the complexity of her losses provides a rich opportunity for consultation. The client is a 60-year-old Caucasian Christian male, I'm sorry, Christian female, who is currently single and divorced twice. She is the mother of three adult children. She has participated in counseling in the past and reports positively outcomes from that therapy, particularly helping her to leave an abusive marriage. She also has previous experience with EMDR and mindfulness practices, which makes it really helpful in the work we're doing together. The client sought treatment again because she wanted deeper healing related to losses that she feels were never fully grief. One important aspect of this case is the accumulation of losses. The first major loss occurred when she was only 6 years old and her mother abandoned her. In early adulthood, where her high school sweetheart died by suicide after years of mental health struggles, and she was one of the last persons he spoke to and told her that he was going to do it. Despite her attempting to discourage him, he still followed through and was successful. Um, Approximately 11 months later, the man she describes as the love of her life died in a fatal accident. She also experienced losses associated with divorce, relocation, friendships, and eventually the progress of cognitive decline of her father due to Alzheimer's disease. She decided this has been going on for 20 years, and she decided to stop going to visit her father because it was over and over like losing him. And this is something that her siblings and her family does not understand and do not approve. So she is also feeling isolated in this experience. The event that brought her back to therapy was the suicide death of one of her mentees' boyfriend, which activated unresolved grief from her own past, where she realized how young she was, because her mentee is around the same age that she was when her high school sweetheart committed suicide, and that kind of like started to surface all of these experiences she has had and that have been unresolved. The client was the middle child of three siblings, and following her mother's departure, she assumed significant caregiving responsibility not only for her younger brother, where she became emotionally invested in protecting her father. In the work that we're doing, she realized that a lot of this vow that she made, like I'm gonna make everything possible to make it a little easier for my dad, was fear based. She was afraid that dad will also leave her the same way that mom did. She also experienced bullying from her older sister, who would call her names and mistreat her. And as she explored her developmental history, themes of parentification, emotional neglect, hyper responsibility became increasingly apparent. She learned very early that her role was to care for others than to attend to herself and her own emotional needs. My grief conceptualization includes several overlapping constructs. First, accumulative grief. The client has experienced repeated losses throughout her life without adequate opportunities for processing and integration. And second, disfranchised grief. The significance of some of her losses, particularly her romantic losses, may not have been fully validated by others. Third, ambiguous loss. Her father remains physically alive but psychologically unavailable due to Alzheimer's disease. And I think this is a major loss as well because this was her anchor. Like had a really close relationship to her dad, as she describes it. Finally, survivor guilt that may be present in relationship to the suicide of her high school sweetheart. Attachment theory became one of the most useful lenses for understanding this case. My working hypothesis is that maternal abandonment created the primary attachment wound. Every major loss thereafter appears to reactivate aspects of the original injury. The client learned that relationships can disappear unexpectedly and that maintaining connection often requires caregiving and self sacrifice. IFS serves as a primary treatment framework. Several exiles appeared central to the case, including the 6-year-old abandonment child and younger adult parts carrying grief associated with the death of significant attachment figures. Protective managers include the caretaker who protects others and strong part that suppresses emotions and prioritizes functioning. Treatment focuses on helping the client access self energy and develop compassionate relationships between these parts. Interpersonal neurobiology helps explain how the client's nervous system adapted to chronic attachment disruptions. Emotional suppression became a survival strategy. The therapeutic relationship serves as a source of co-regulation, allowing the client remain within her window of tolerance while exploring difficult memories. One of the most significant indicators of progress have been her ability to cry while maintaining or remaining emotionally regulated. In session 3, the client connected with her 6-year-old self and revisited the moment when her father explained to her that her mother was not returning. She comforted this younger part and cried for the first time. This was one goal that she had, to be able to connect with her emotions, as there has been this disconnection where she hasn't been able to cry for years. During this exercise, she was able to be in touch with this younger self and care for her. In session 4, she connected with her younger adult, grieving the death of her romantic partner, and was able to cry again. These moments represented movement from the intellectual understanding toward emotional integration. Since our last session, when we reviewed these two moments where she had like this integration with younger parts, the client said that she's more aware of her inner child and that she's able to express gratitude and have conversations with her where she really likes and loves this part of her. And it sounds like she continued the work outside of the therapeutic room. This case required consistent use of advanced counseling skills rather than focusing on problem solving. I am prioritizing the therapeutic presence, emotional attunement, and pacing. Grounding and visualization interventions help the client remain regulated while approaching painful material. The therapeutic relationship itself became an important intervention. Faith seems to be central to the client's identity. Rather than introducing a spirituality, I follow her lead and incorporate in spiritual themes when they naturally emerge. Her faith appears to strengthen her resilience and facilitate meaning making throughout the grief process. One area of self reflection involves my emotional response to the client. If I'm honest, I really like this client, and I noticed significant empathy and admiration for her resilience. I also reflected on a recent disclosure that I had in regards to an upcoming surgery that I'm having. And although I believe the disclosure was clinically appropriate, because she asked me why I was going to be away for such a long time, it prompted reflection regarding boundaries and my investment in the therapeutic relationship. These are the primary questions that I hope to explore through consultation. I am particularly interested in feedback regarding the interaction between grief and attachment trauma, as well as recommendation for assessment and treatment planning. Um, Kind of like on the role of survivor guilt, what interventions you might recommend, any additional assessments that I should keep in mind. So any feedback is welcome. My current formulation is that the client's symptoms are best understood through the interaction of attachment trauma, cumulative grief, ambiguous loss, and disfranchised grief. The primary treatment goal is not simply processing individual losses, but facilitating the integration of attachment wounds, grief experiences, and protective adaptations through self leadership, co regulation, and meaning reconstruction, as well as utilizing her spiritual resources. I thank you for your time in listening to my presentation, and I welcome any feedback and consultation.